Good afternoon. Thank you for joining us here. I'm going to continue on, add to Jordan's presentation by talking about the NCQA's recognition process. More specifically, the standards and elements and generally the criteria involved that the NCQA is asking for in terms of formalized recognition. I'm going to talk about it at a very high level because there's just a ton of information that's required. I just want to touch on some of the more salient points just to give you a flavor of what's involved, what your practice needs to be aware of when you're looking to go down this route. Quick background on the NCQA. They're a not-for-profit group up in Washington, D.C. They're dedicated to healthcare quality improvement. They have many initiatives and programs that providers and health plans participate in, including the diabetes and the heart stroke recognition program. Many of you are familiar with the HEDIS quality reporting. That's NCQA's baby. And of course, the PCMH recognition program there. As Jordan mentioned before, I want to touch on the joint principles of PCMH just to give you an idea of why the NCQA chose to create their framework for recognition. As Jordan said, back in 2007, several medical associations and groups formally defined the foundation of what a patient-centered medical home is. So when you read through the literature, you'll see various groups and organizations describe what a patient-centered medical home is. But again, as Jordan said, in essence, they all build off of that collaborative work of those major groups back in 2007. So they called for the medical practice to offer each patient a personal clinician who would lead the healthcare team and coordinate the care of the patient. And then they stipulated that this must all be done under the supervision of a physician, but also in a team-based approach. And this healthcare team would then take, like Jordan said before, a whole person orientation. So it's not going to be just about diagnosing the patient as obese and diabetic, throwing some prescriptions at them and then asking them to come back in 3 months. A more thorough understanding and assessment, a deeper assessment of what's actually going on with the patient, what factors in their life are contributing to their current health state, what is it about their cultural or socioeconomic environment that contributes to their well-being, and then having the care team integrate all that information into individualized treatment plans for the patient. They called for coordinated care, meaning that referrals are followed up on. The patient is called in between visits, basically trying to take a proactive approach to prevent things from falling through the cracks because that's where gaps in care occur. At the same time, the practice takes a vested interest in improving how they deliver care to their patients. So qualitative and quantitative measurements can provide feedback to the practice and identify opportunities for areas of improvement and how the practice can act on those. Improved access, enhanced access down there. Improved access to healthcare has always been a goal. In rural areas, it's always been a challenge just to get the appropriate levels of primary and urgent care, but also in the urban areas where people need to see a doctor for non-emergent needs, but then wind up going into the emergency room to get treated. Last, those organizations that develop these joint principles recognize that payment reform for primary care services needs to be revamped in order to appropriately reimburse the efforts that go into this type of coordinated care and innovative models like the patient-centered medical home. So the NCQA took all of these principles into consideration and incorporated into their recognition program and incorporated into their actual criteria sets for what practices have to do in order to become formally recognized. Additionally, the NCQA defines how they will determine the level of patient-centered medical home that a practice qualifies for, and we're talking about levels 1, 2, and 3, which you might be familiar with. So the higher levels, the 2s, and definitely level 3, might indicate more how closely your practice aligns with the ideals of an ideal patient-centered medical home, or how engaged that practice is in terms of doing more of those patient-centered medical home activities. They also define what a practice is, a single clinician or a group of clinicians that practice at a single location. They also recognize that in terms of being able to provide a personal clinician, nurse practitioners and physician assistants are important extenders in that treatment of care in certain areas. And then last there, recognition by the NCQA is done at the site level. So if you have a practice that has 5 sites, for example, maybe site number 1 is formally recognized by the NCQA as a PCMH, but then sites 2, 3, 4, and 5 may not be. By the way, the NCQA has a really good roadmap on their website. It's actually like a flow chart that gives a high-level overview of the recognition process on their end. It talks about how to sign up on their for the application, when to submit documentation that's required for recognition through their portal, which they call the ISS survey tool. And it shows you basically what you can anticipate at a very high level. So now let's get on to kind of the crux of this whole recognition process, the standards, the elements, and the factors. The NCQA recognition process is based on an accumulation of points against the specified criteria outlined in their PCMH recognition program. So these criteria are categorized into standards, which are then broken down into elements, and then each element is then further broken down and detailed into factors, scorable factors, and that's actually where you get your points at the factor level. So if you go through the transformation process with your practice to become a medical home, and you compare what you have in place to what the NCQA says constitutes a patient-centered medical home, you're going to be able to determine what level of PCMH recognition your practice qualifies for. So you might be performing those medical home functions that get you 35 points when you compare it to the NCQA requirements. And if you have between 35 and 64 points, you qualify for level 1 recognition. Level 2 requires that the practice perform enough of those medical home things on the list of NCQA PCMH criteria to accumulate 65 to 84 points, and then level 3 is the highest level, and that requires that your practice do those medical home functions that garner 85 to 100 points. This slide you have in your handout. This chart basically just says that there are a total of 6 standards, 28 elements, and 152 factors in the NCQA 2011 PCMH program requirements. It doesn't even go into all the detail of all 152 factors. It just be aware that there's 152 of them. You can see where the points are associated with your standards in those salmon-colored rows. Those are the standards. The number of points for each element are in white, and then the yellow rows highlight the what's called the must-pass elements. So I'm going to move on to standards 1 and standards 2. Before that, I'll just kind of mention quickly what are standards. The NCQA created these 6 areas or domains that it feels reflects the major components of the modern medical home, and these are called the standards. There's 6 of them there. They emphasize patient-centeredness and patient care experience. The standards reinforce the incentives for meaningful use and the use of health information technology in general. They focus attention on the aspects of primary care that reduce cost and improve quality. And the standards are based in evidence and also the changes in practice capabilities. The next box over are the must-pass elements. What are must-pass elements? Each of the standards contains an item that reflects a pillar or foundation of what a medical home is, and these are referred to as the must-pass elements. So a practice must receive a passing score on each and every single one of these must-pass elements, or there is absolutely no chance of formal recognition. So the remainder of my exciting presentation is going to be a high-level overview of the 6 standards and the NCQA PCMH recognition. I'm going to describe the intent of each standard and what the standards entail. For those of you involved in the Meaningful Use Incentive Program, I'll touch base on what meaningful use items relate to each standard. I think Jordan mentioned earlier that you can get some of your PCMH points from achieving meaningful use. You can actually get up to about 20.5 points towards PCMH recognition. And if you remember, it's just 35 points for level 1 recognition, so you're more than 2/3 of the way there, if I did my math correctly. You don't, as Jordan said, or someone had asked, you don't actually need to have an EHR to achieve formal recognition, but again, having an EHR can expedite those reports that you need. It can create efficiencies in communication between your healthcare team. It can enhance communication to providers outside of your practice, and also enhance that communication with your patients. Definitely for the higher levels of PCMH, levels 2 and 3, you're going to need an EHR, and definitely for compliance with the quality metrics that the payers will ultimately ask for, it's going to be necessary to have an integrated and complete system. So if we look at this first slide here, this is Standard 1, Enhance Access and Continuity. This standard covers the practice's ability to accommodate for things like walk-ins, extended hours, providing clinical assistance during and after regular business hours with cultural and language needs in mind. It also covers whether or not your patients have electronic access to their medical information, and whether or not the patient can select their own personal clinician if it's something other than a solo practice. And then how this standard also looks into how the practice structures a team-based approach to healthcare. Regarding meaningful use, the standard relates to, again, providing a copy of the electronic information to the patient, having access to electronic information, and providing the clinical visit summaries. The worst part of my presentation is it's right after lunch, so I will not be offended if you yawn. So you can get up to 20 points for Standard 1, and you can see the points here are distributed among 7 elements. For example, in element A, if you can demonstrate how your medical home offers enhanced access during office hours, again, your walk-in policies or how responsive your clinicians are to returning phone calls and messages left by the patient, that's a must-pass element. You can get 4 points on that. Again, you must receive a passing score on the must-pass element in order to receive PCMH recognition. For must-pass elements, you only need 50% of the allowable points. So in this case, 50% of 4 points is 2. So how do I get 50%? Again, that's going to be determined by the number of factors that your practice achieves, because remember, the standards are broken down into elements, and then each one of these elements is further broken down into factors. So if we look at element A, access during office hours, you can see the 4 factors there that make up this element. Provide same-day appointments, provide timely advice by telephone, timely advice by electronic message, and then the ability to document in the clinical advice in the patient's chart. To make things a little bit even more exciting, they threw in there something called the critical factor. Critical factors are something like must-pass elements. You need to achieve, in particular, this critical factor here to receive any points on the element of access during office hours. You don't need to achieve every single factor. Your practice is only going to be scored upon the factors that it actively does do and what policies are in place to support it. But if we look at this scoring rubric here, and this shows you how the practice actually accumulates any points. For PCMH Standard 1, Element A, if your practice shows that it does all 4 of those factors, then you get 100% of the points, which is 4 points. If you only do 3 of those factors, then that's 75% of 4 points, and so forth and so on. In addition to all of this, you're going to need documentation, supporting documentation. And the NCQA basically looks at 3 major things: policies, procedures, reports from your electronic systems. It also looks at other things like screenshots and some other supporting materials that your practice may be involved in, but basically those are the 3 things there. You're going to need those to support your attestation saying that you actually do offer after hours for your patients. I'm going to go back a couple of slides here, so just to recap here. So again, each element has its own set number of factors, and how many factors your practice achieves will determine how many points you get for that element. So for element B, you can get up to 4 points. Element C, you can get up to 2 points. Here's an example of supporting documentation for element G of Standard 1, referring to care team responsibilities. Element G has to do with the practice team and how pre-visit preps are performed and how standing orders are initiated and structured. Excuse me. But basically, this is the kind of document that the NCQA will look at to, in support of your practice, attesting to the fact that you actually do pre-visit preps and that there are actually a policy for standing orders. Moving on to Standard 2, the standard basically asks whether the practice has a computerized system with searchable discrete data fields, and if the practice is able to utilize that to identify patients in need of services. So again, like Jordan mentioned before, do you use your EHR's registry? And I know that it's an obstacle for some practices, but it's an opportunity to identify other opportunities to help your patients in need. Do you use your EHR's registry to identify those patients who haven't been in over a year for their yearly physicals? Basically, the concept behind this is that it's hard to do on paper. It's very time-consuming, it's very costly, and resource-intensive to do this through paper. But this standard also covers how the practice performs its comprehensive health assessments. So it's going to ask things like about the information about the cultural background of the patient. Do you capture that information as it pertains to possible treatment considerations? Does the patient need translator or assistive devices if they're hearing impaired or visually impaired? As we move forward in healthcare and they identify identifying the need to address mental health and behavioral issues as well, this standard also asks about how you incorporate mental health and behavioral screening tools in your comprehensive health assessment. So do you use a standardized depression screening tool during your assessment? In regards to meaningful use, it relates to capturing demographics, vital signs, other clinical data in structured formats, and then using the system to generate patient reminders. These are the elements that make up Standard 2. If your medical home can get up to 16 points, and you can see how they're distributed over here. I'll touch base on the must-pass element here. It covers generating patient lists by condition, by chronic care condition, for example, identifying preventive care opportunities, and generating lists of patients by medication. So, for example, if there's a recall on Plavix, and you can use your EHR's registry to quickly identify all those patients in your practice that are on that were prescribed that medication, and then you can quickly contact them to tell them to stop taking the medication. This example here just shows how one practice documents pertinent information on their patients, and this here satisfies the NCQA required documentation for searchable patient data. Standards 3 and 4, we're halfway there, almost. Standard 3 asks the practice to show how it actually implements evidence-based care, how high-risk patients are identified, and how the care team actually performs actual care management. The meaningful use items here are related to using the EHR's CDS, clinical decision support rules, those health maintenance alerts, maintaining up-to-date medication lists, and performing medication reconciliation when appropriate, and electronically prescribing your medications. So you can get up to 17 points on this particular standard by showing how you implement evidence-based guidelines, identify your high-risk patients, and the NCQA does not say what high-risk patients are. That's up to you to determine within your practice based on whatever's relative to the population that you treat. Element C is the must-pass element, and again, you'll need 2 out of the 4 must-pass elements. 2 out of the 4 points. But this is pertaining to individualized treatment plans and creating that treatment plan with the patient and their family if necessary, giving them the copy of the individualized treatment plan, also finding out what the barriers are specific to that patient for in terms of their treatment. So, for example, why are they missing appointments? Why is there non-compliance on their side? With this practice's policies, they mention with the American Diabetes Association and how they use their guidelines to support diabetes screening and their criteria for diagnosis and the process for treatment goals. So the reason why I'm showing you this is that you might be doing all of this stuff in your practice, but and you might have all this information in your head, but if you don't have it written down someplace into a format that's similar to this, the NCQA will not give you any points for that. Basically, they'll say, well, there's no proof that you're actually doing any of that stuff. Standard 4 covers the domain of providing self-care tools and community resources to the patient. It's pretty straightforward. Here, the meaningful use item is related to generating educational resources through your EHR. In regards to the self-support, this kind of goes beyond the typical guidance and counseling that you give your patients during an exam, but it also refers to providing them with brochures, handouts, links to websites and videos pertaining to self-management programs like diabetes classes, weight loss classes, nutritional classes. Also has to do with providing the patient with blood pressure logs or the blood glucose finger stick logs. Element B asks whether or not you maintain a list of external resources for your patients, and we're not talking about like the referrals to the orthopedic specialist. We're just talking about community resources, educational related to their treatment goals. And asks about how you go about tracking those referrals, or whether or not you actually offer any in-house educational classes. In element B, factor 1, all it asks is that your that your practice keeps a list of at least 5 community resources that are applicable to your patient population. So a simple spreadsheet, list of names, address, phone number for those resources in your community. If you can do this, you get 3/4 of a point towards recognition. Well, you know, when you consider the requirements for PCMH recognition and how it's based on an accumulation of points, and the points are at the factor level, and there's 152 factors, every point or partial point counts and gets you closer to higher levels of PCMH recognition. So if you can just do this, pick 5 resources, you're on your way to becoming a medical home. The last 2 standards here, standards 5 and 6. Standard 5, here's a big one, and by big I mean that this standard might necessitate the practice acquiring additional resources, because it does deal with resource intensive criteria here. It has to do with monitoring and tracking care in between office visits. It also has to do with tracking labs, lab and imaging results, and tracking and following referrals. It also has to do with coordinating and communicating with the hospitals or other healthcare organizations that your practice deals with. The meaningful use items here have to do with capturing lab values into structured fields, electronically exchanging clinical information with other organizations, and providing them with the continuity of care, or the CCD file, for your referrals and transactions. And no, faxing does not count as electronic submission. Each element that creates, constitutes standard 5 has anywhere from 7 to 10 factors, and that's a lot more than many of the other factors and elements throughout this recognition process. So this kind of tells you how much weight is being put on the standard in particular. Element B is the must-pass element, and it deals with your referral and tracking system and the documentation that's needed to support the process that your practice has in place for that. I chose this one because it shows that the documentation doesn't need to be super sophisticated. So here what we're looking at for element A of standard 5, notification of abnormal results. If you see in the lower right-hand corner, it's just basically a handwritten note by the provider saying that the abnormal result was communicated to the patient, and that some recommendations were given. The doctor signed it, dated it, and then they scanned it into the EHR and attached it to the patient chart. And this was accepted by the NCQA as proof that abnormal results are communicated to the patient for this practice. And last, we have Standard 6. Standard 6 asks how the practice uses performance data to identify opportunities for improvement, and how it acts to improve on things like clinical quality, efficiency, and patient experience. For those keeping track of the meaningful use items, we're talking about sending the clinical quality measures to CMS, sending your immunization data to Florida Shots, and then at some point we'll be able to report syndromic surveillance data to the state. For this measure, you'll have to identify your preventive health and your screening measures that you use in your practice, how the practice performs on all these items in order to understand how your care delivery process and its strengths and opportunities for improvement. You'll also need to conduct patient and family surveys on a regular basis to get feedback on their experience and then use that data to rectify any discrepancies or deficiencies in that area. For element C, the must-pass element, the practice needs to show a clear ongoing quality improvement and strategy and process. And that includes regular review of performance data and how it measures up against its own internal goals and benchmarks. Element D continues that concept and then asks the practice to show continuous quality improvement over a period of time, and that's 90 days. And then elements E and F have to do with sharing the results of your quality projects internally with staff, also with your patients, if possible, and then also reporting clinical data. In our case, it would be Florida shots for immunization data. And then element G is just, NCQA just wants to know if you're using certified EHR technology or not. You don't get any points either way. They just wanted you to do that extra step to make sure that you're totally invested in this process. But my last example here just shows performance improvement for a practice over time. Items like how happy the patient is with the wait time, how well things were explained to them, et cetera. Again, the documentation does not need to be super sophisticated as long as the NCQA reviewer can identify what they're looking at. The practice will have the opportunity to mark or comment on what items the NCQA reviewer is looking at to help expedite the process so there's not any confusion. So at this point, you're saying, Randy, that was really boring, or you're saying, Randy, that's way too much information, or maybe you're saying both. But that's what the Regional Extension Center is here for. Earlier this year, Jordan and I were able to go through the rigorous training at the NCQA for their patient-centered medical home recognition process. And after reviewing all the standards and elements and learning about what documents are acceptable as proof for the factors that your practice performs, it was then capped off by a national certification exam. And Jordan and I were amongst the first in the nation in that cohort. So again, to kind of reiterate what Jordan had said earlier, when you work with the REC, should you choose to transform your practice into a patient-centered medical home, or even go the extra step of becoming formally recognized, we'll be here as a partner for you, using that insider knowledge that we gained from the NCQA experience to help develop the baseline assessment, analyze the gap analysis, build that roadmap to where your practice wants to be, and then help you through the change management and transformation process. So again, I know that there's a lot more information, and I spoke to it at a very high level, but I appreciate your time in letting me speak to you on this.